Hi, everyone. We'll give it another minute or two to let everyone join. Alrighty, let's go ahead and get started. Hello, everyone, and welcome to today's webinar, Point of Care Testing, Why Rapid Results Matter in Urgent Care. My name is Samantha Burke, and I am NERUCA's Administrative Director. I'll be your moderator today. This webinar is co-sponsored with BD Diagnostics, and I am joined by Jennifer Gerard, Marketing Manager for Point of Care. But before we start, I do want to go over some housekeeping items. Today's webinar is being recorded, and we invite you to submit your questions by using the Q&A box at the bottom of the screen. For those of you who don't know, NERUCA is in its 11th year of existence, and today we provide grassroots local representation in partnership with UCA's National Strength. We tackle legislative issues at the state level, and we provide education and advocacy for urgent care medicine in the Northeast. We do this through programming, including today's webinar, and our annual conference, which is our signature event of the year. So for everyone, our next conference will be located at Foxwoods in Connecticut. It'll be held from September 28th to September 30th. So please be on the lookout for our save the dates to come. Now, our next webinar that we will host will be tomorrow, December 5th at noon Eastern Time. The title of that webinar will be Surprising Insights from Your Urgent Care Payer Data, and the presenter will be Aptitude Medical Systems. Now, lastly, I would like to thank all of our Platinum sponsors for their continuing support. Shout out to Aptitude Medical Systems, to Xperity, to HealthTrack RX, Medline, and last but not least, today's sponsor, BD. Those interested in either sponsoring or perhaps exhibiting or speaking should be receiving communication shortly, but always feel free to reach out to us at admin@neruca.org with any questions or comments that you may have. And with that, it is my distinct pleasure to introduce you to our speaker today, Dr. Amesh Adalja, and who is affiliated with BD and adjunct assistant professor at Johns Hopkins University, Carnegie Mellon University, and the University of Pittsburgh. So with that, take it away.
Thank you for the introduction. Thank you for inviting me to speak. And I'll give you a couple little tidbits about me and why I'm here. So I am a senior scholar at the Johns Hopkins Center for Health Security, which is a think tank focused on pandemic preparedness, biosecurity, emerging infectious disease. And the other part of my time, I'm a practicing infectious disease, critical care, and emergency medicine physician in Pittsburgh. So I kind of straddle both the policy as well as the frontline clinical work. And I've taken a large interest in diagnostic testing as part of a way to increase infectious disease resiliency around the world and even locally. And that's why this topic is something that's kind of important to me. And I'm always advocating for better diagnostic testing. So in the next 45 to 50 minutes or so, I'm going to take you kind of on a whirlwind tour of why I think point of care testing is really important and what kind of information it gives you, not just to the patient in front of you, but to the entire ecosystem of public health, of infectious disease, of medicine in general. And that's kind of going to be the underlying theme. And there's my Twitter handle is there if anybody is active on Twitter, if they want to follow me. I tweet a lot about infectious disease. So I'm going to go through a couple of different concepts throughout the talk. One is, why do we even diagnose? What's important? Why is it important to diagnose things down to a specific name, a specific etiology? I'm going to talk about a concept that's kind of a favorite of mine called biological dark matter, and I'll explain what that means in a couple of minutes. I'm going to talk about antibiotic resistance because that's a place where I think urgent care providers can really do a lot of good. And I think armed with diagnostic testing, it makes it so much easier to do a lot of good when it comes to antibiotic resistance prevention. And then talk about how you can integrate point of care diagnostic technology into care. So as you heard earlier, this presentation is on behalf on BD. There's not really anything specific about BD in this presentation. This is all informational purposes, and I am getting compensated by BD to give this talk. So why do we diagnose? And I have this little, like my first little tidbit there thing says Rumpelstiltskin. Most people remember that German folklore. And just for people who don't remember that, there is this kind of creature, this troll type thing, and he's kind of menacing a person, and that person gains control over over Rumpelstiltskin when she guesses his name. The power comes from naming him, because once you name something, you can actually do a lot with it, even if there's not a specific treatment for it. So when you name that someone having a specific diagnosis, like RSV, for example, while there's not a specific RSV antiviral we give people, you know a lot about RSV. You can give the family, the patient prognosis, what signs to look out for, and you can refrain from giving them antibiotics. So you gain power over that disease entity by knowing what's causing it. And we do this all the time in medicine. Once you know what something is, that kind of dictates how you proceed. But we don't often do that with milder illnesses, especially upper respiratory infections. And I'm going to talk about why that's important. But it really comes back to the power in naming things. And it's very important to know what's making people sick. I think if you continue to just treat things symptomatically without knowing what makes people sick, you really don't know what you're treating. And then you have people trying all different types of remedies. You don't know what's working, what's not working, because you don't know actually what made a person sick. So I think it's really important to know what makes people sick when it comes to infectious diseases. We would never do that, for example, in cancer, where we'd say, you've got some type of cancer. We don't know what kind it is. Here, try this. But with infectious diseases, it's often the norm to just say, oh, you've got a cold or you've got a GI illness, but you don't tell people what they actually have. And that leaves a lot of uncertainty. And there are separate treatment pathways that can be kind of initiated based on knowing what people have. The treatment pathway might just be, don't give them antibiotics, or it could be, don't give them steroids if they have influenza, or it could be prescribe them a specific antiviral for influenza or for COVID. Or if it's none of those things, if it's group A strep, put them on an antibiotic for group A strep. So this does guide treatment. It's not just kind of an academic exercise. And there is a lot of value in knowing what makes people sick when it comes to epidemiology, because that's how we know that things are spreading in a community. For example, mycoplasma, which you might have seen in the headlines. We know that that's spreading because people are testing for it in a way that they weren't able to do before. So that epidemiology then influences how public health experts gauge a season, what advice they give the public, what resources get mobilized. And you can imagine, even if, suppose in a town, you guys are all doing rapid tests on people and they're all coming up negative, but all these people have some sickness, some flu-like illness. That's a signal something odd is going on there. And I'll talk about that in a second, but that can give you the kind of hint that something new is occurring in a given community. So there is a big input into epidemiology if you can actually figure out what's making people sick in a given community. So there's a lot of different reasons why we diagnose. And one of the concepts that I mentioned earlier is biological dark matter. And I kind of came up with this idea because I think that when you look at infectious disease syndromes, ranging from upper respiratory illnesses to GI illnesses to even septic shock, a lot of times we don't know what's making people sick. And I call that the biological dark matter. We don't know what's lurking in that person's in their body, what's making them sick. And within that biological dark matter are really important things. They could be new epidemiological trends that you're seeing with the pathogen, a novel emerging infectious disease that's appearing. And I think we can't just kind of leave this biological dark matter hanging and wait until there's so many of these cases that all of a sudden somebody says, well, maybe we should test these people a little bit more aggressively to figure out what's making them sick. And I think that's kind of the concept, is trying to illuminate biological dark matter so you don't have these mystery illnesses, so that you have good situational awareness. And I'm going to kind of take a little bit of a jump to take a step back and think about infectious disease, because after all, I am an infectious disease doctor that thinks about how society interfaces with infectious disease. And I think some of the more interesting things that maybe you'll take away from this is that when you think about the human species, we went from a nomadic species to agriculture, which then led to people living together in close proximity with their animals. And they call that the age of pestilence and famine. And that's not for no reason. It's because that's when pathogen transmission started to really accelerate. And we moved to the Industrial Revolution, sanitation, antibiotics, vaccines. That led to the age of receding epidemics. But now we have globalization. You can get from one part of the planet to another part of the planet in 24 hours. Urbanization, the growth of megacities, aging, immunocompromised individuals, and now we have this age of degenerative and man-made diseases. And you can see that this is, I think, really important, because for the most of the human evolution, we've been a nomadic species. It's a very short period of time that we've had infectious disease be a problem. And as I mentioned earlier, all of these things happen when people live together. So when you think about COVID, for example, which is fresh in people's minds, or you think about influenza or any respiratory viruses, there are many different factors that lead to increasing transmission of pathogens. So this is only becoming more and more common. And as I said, evolution works on tens of thousands of years. We've not had that many years in an urban industrial environment. So these infectious disease threats are going to continue to appear. So it's not some kind of accident that this is happening or coincidence. All of these factors are converging that lead to more infectious disease spread. And that's why it's very important to know what's making people sick, because all of these syndromes, exotic, ordinary, they all have overlapping symptoms, and you're never going to know unless you actually test people systematically to know what's making them sick, to know there's a change in the pattern or there's a new pathogen that's appearing. Some of the work that I did that I'm kind of most proud of was this report called The Characteristic of Pandemic Pathogens, the Characteristics of Pandemic Pathogens. And you can find this on the web if you want. It's a report published by Johns Hopkins. And what I tried to do there is understand what it takes for a pathogen to cause a pandemic. And there's a fad where everybody says everything can cause a pandemic, and that's not true. I think there are only certain pathogens that have the ability to cause an acute disruptive pandemic. And I kind of narrow it down to these kind of factors. So efficient transmissibility from human to human. You have to be able to spread from person to person. A moderate fatality rate. People need to be able to go about their daily life and spread the infection. So a high fatality rate where everybody is dying and in bed and is not going to spread very efficiently. And related to that, contagiousness during the incubation period. That's another factor that's really important when it comes to being able to cause a pandemic, because if people are not sick at all, yet contagious, that will allow a pathogen to spread unbeknownst. It's kind of silent spread until it bubbles up and causes disease. And that's really instrumental in starting a pandemic. So something that's contagious during its incubation period, all bets are off on how far it will get, because by the time you notice it, it's probably all over the world. And the same goes for mild illnesses with contagiousness. As long as people are out there spreading the infection, it's going to find new hosts. Immunologically naive population, so it has to be something that the human race has not, the human species has not seen before, that they don't have protection from, they don't have cross protection from. There has to be something that can infect basically everybody. There's no vaccine or treatment that's ready off the shelf, and it has to be able to evade host immune responses by being able to mutate or being able to get around the general innate immune defenses that might be present in a human. So these are the things that kind of put those things together, and you get a pandemic pathogen. And when you map that onto all the known types of things that can infect us, from prions to fungi to bacteria to viruses, it's really respiratory viruses that have this capacity almost exclusively in the modern world. And before the advent of antibiotics, there were certain bacteria that could do this, like plague, most famously, which killed 1/3 of Europe during the Black Death in the 13th to 14th centuries. But right now, it's really respiratory viruses. And what do we know about respiratory viruses? That in an urgent care setting, you see so many of them. And hidden among them, that's that biological dark matter. It might be a mild case of something new. So that's why I really emphasize figuring out what's making people sick. And I often talk about taking respiratory viruses seriously. And that means not just telling your patient you've got some virus. Because remember, there's biological dark matter there. You want to know what's actually making them sick. And remember, there's a spectrum of illness. You might be seeing a mild case of sniffles, but that person might then go infect their immunocompromised brother, and that person has fulminant pneumonia, but no one knows what made him sick because no one tested to figure out what was going on in the initial index cases. So remember, there's a spectrum of illness from very mild to very severe, and you may be seeing just one side of the spectrum in an urgent care setting, but it may be the clue to something going on. And as I said before, when you get a specific diagnosis like influenza, like COVID, and hopefully more in the future, you can link people to antiviral therapy. And now I'm going to kind of move to talk about antiviral therapy because I think this is something where we do a poor job. So looking at testing for community-acquired pneumonia, this is just an example of what happens when you look. So when people think about community-acquired pneumonia, everybody says, oh, pneumococcus or mycoplasma or chlamydophila. The most common cause of community-acquired pneumonia is a virus, rhinoviruses, the same viruses that cause the common cold. That's the most common cause of community-acquired pneumonia. How many patients with community-acquired pneumonia get antibiotics? Almost 100%. How many need it? Probably not, definitely not 100%. So this is one area where you could think about refraining from antibiotic prescribing if you knew that someone had a virus causing their community-acquired pneumonia. There may be co-infections and you need to think about that, but in general, remember viruses do a lot more than just cause the cold. Another point I wanted to make is about antibiotic resistance, and I call this the war of the worlds, because basically, I always tell people, if you're an alien looking down at the planet Earth, and you've been asked to survey it, you would say that's a planet of bacteria, fungi, viruses, some protozoa, and some other things. We live in a world that teems with microbiological life. So when you see these types of articles that say, "What's the dirtiest part of your house?" Every part of your house has bacteria. Every part of you has bacteria. You have more bacterial cells in you than human cells. So these germaphobes sometimes really get on my nerves because you can't actually have a sterile life. And if you were completely sterile, your blood wouldn't clot, because remember, vitamin K comes from the bacterial species in your microbiome that synthesize vitamin K. And this isn't something new, although you're seeing it a lot in the headlines. There's been major United Nations high-level meetings on antimicrobial resistance, but this is something that Alexander Fleming recognized very early on. And for those who need a reminder, Alexander Fleming, winner of the Nobel Prize, the discoverer of penicillin in the 1920s, which then went on to commercialization in the 1940s, where he realized that it was very easy to make microbes resistant to penicillin. And this can happen in humans. So this is something that was predicted and then came true, and only has accelerated. And if you just do any kind of headline search, you'll just see these types of headlines. Bad news about nightmare bacteria, superbugs, scary superbugs, CRE, ESBLs, MRSA, VRE. There's so many of them. And it comes from injudicious use of antibiotics, both in the clinical world as well as in the agricultural world as well. And that's just creating a major problem. And I think part of the reason why injudicious antibiotic use persists in healthcare settings is people are not confident that they've got the diagnosis right, because they're not using all the diagnostic tools at their behest in order to be able to rule out bacterial infections and rule in viral infections. So I think that many people just try to play it safe, that they don't know if an illness is bacterial or viral. They don't have the ability to do things like CRPs, procalcitonin, and some physicians might be unfamiliar. So they just in case, give people an antibiotic. Or maybe that's what they were taught, or that's the easiest thing to do, or they think the patient expects an antibiotic, or they think their manager is going to, if that person writes a complaint, the administration is going to come and say, why do you just prescribe this patient an antibiotic? That's driving a lot of that use. And I think when you arm people with tests, they actually do better sometimes. So this is a striking counterexample, but I think it really illustrates what I was mentioning earlier about antiviral prescribing in 2013. So this is after the 2009 H1N1 pandemic. If people were PCR confirmed flu cases, only 15% got an antiviral, but twice as many got an antibacterial agent. So we have a lot of work to do when it comes to using antivirals optimally. The same is true now for COVID antivirals. Many patients that would benefit from COVID antivirals, and I hope somebody asks me about that in the question period, don't get them. They're really underutilized. And COVID-19 is now basically something that is preventable. The hospitalizations can be largely preventable if people are early on linked to antivirals like Paxlovid or molnupiravir. And I mentioned molnupiravir just for completion because many people forget that it exists and they're intimidated by the drug-drug interactions of Paxlovid, which are manageable, but sometimes people are intimidated by them. There is another drug called molnupiravir that you can also prescribe, but we do very bad. People get more likely to get a Z-Pak than they get Tamiflu. Another area where this has been highlighted is in pediatric flu patients who are really at high risk for severe complications of influenza are not getting antivirals. And that's a major issue. So I think diagnosing is part of it, but you also have to then link that to treatment. So you can look here. Here's another study. Less than 50% of suspected pneumonia patients in the ICUs are tested for respiratory viruses. So this is just people not actually being aware that these viruses are circulating and causing severe disease. They just assume it's bacterial and put antibiotics on board, but don't even look to see if there's a virus there. So I think of diagnostic tests really as part of a physician or provider empowerment. There are ways to better steward antibiotics and better steward antivirals. Because if you can diagnose somebody with a specific disease, then they're less likely to demand an inappropriate treatment like antibiotics. People like to know what they have. They can then post that on Facebook and get sympathy. They can't get sympathy if they just say, I have a virus. If they can say, I have metapneumovirus, or I have RSV, or I have this, people get sympathy. And that's a little bit of a joke, but that's actually true. People like to know what they have, and they like to tell people what they have, usually. And I can tell you a funny story about that if people are interested in the question period. So what do? I try to use all tools at hand, especially those that are CLIA waived and have rapid results so that I can figure out what my patients have. And remember, I'm not always in my infectious disease role. I still work in the emergency department about 3 times per month. And I try to use all of the rapid tests when I'm trying to figure out what somebody has before I discharge them or before I kind of close my diagnostic window. I try to figure that out. And that might include all rapid point of care strep tests, mono tests, influenza, RSV, COVID tests, as well as CRPs and procalcitonins. I tend to be a very liberal user of all of those because I'm trying to drill down and see how sick this patient is and what they're sick with, and then get them on the right path. And I'm also very interested epidemiologically in what's making people sick. So this is a study from 2007 just kind of illustrates what I was trying to say, that when people have rapid tests, they do better at prescribing antivirals as well as not prescribing antibiotics. So I think that providers will do the right thing if they have the test that gives them the confidence that they're making the right diagnosis. So that's why I advocate for using those tests so that you have that confidence so that you can do better with antiviral prescribing and do less antibiotic prescribing when it's unnecessary. So another study there showing that with acute pharyngitis in adults that 30% of negative rapid tests resulted in antibiotic prescribing. That's still better than 100%. So even for rapid strep tests, when they're negative, people are pretty good at not giving antibiotics, not 100%, but pretty good. And that's just what these tools do when they're used. The same thing is true with rapid viral diagnosis on management of children hospitalized with lower respiratory tract. You can see lower length of stays, lower antibiotic use when they make a viral diagnosis. So there is a lot of benefit when people say that this doesn't change treatment. It does change treatment because people get less unnecessary antibiotics and they get a shorter hospital stay when they're diagnosed with something specific rather than kind of a mystery thing that people either get better from or they don't. Even with conjunctivitis, point of care test decreases prescribing of ophthalmic antibiotics. So there is a test that you can do on tears to tell if it's adenovirus or not adenovirus. Those ones that were positive for adenoviruses don't get antibiotics, and that actually had a benefit. So it really is across the board using tests like that. If you look at the antimicrobial stewardship guidelines from the IDSA and SHEA, the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America, they talk about rapid use of rapid viral testing for respiratory pathogens to reduce the use of inappropriate antibiotics. So it is a recommendation from the infectious disease community that these tests be used widely to rule out viral respiratory infections and not give people inappropriate antibiotics. So it is something that is recommended. So the impact of point, so I'm talking kind of broadly about diagnostics and diagnosing infectious syndromes. But when you think about point of care specifically, it is a 21st century solution. It's not something where it has to go all the way to the lab. This is something that can be now near patient. There are CLIA wave forms that can be done in doctors' offices, urgent care centers, emergency departments, and I'm sure you've all used those. The rapid group A strep test has been around forever, but there are now things for influenza. There's things for RSV. There's things for COVID. There are more and more things that are getting put into this position where they can be done at point of care. And the point of care test can either be antigen, which is probably the most common type, but there are also molecular tests as well. And then on the other side, we also still have, we do have, and they are very useful, a multi-analyte syndromic testing panel. So that might be a respiratory pathogen panel that tests for 15 things, or a GI illness panel that tests for a whole bunch of different pathogens from stool. Those things are also coming into vogue now. A lot of hospitals invested in them after COVID-19, and they're still around and they're not being used as optimally as they could. And I think that would really change things if people were testing a lot more with these syndromes. In an urgent care setting, you're most likely to have the rapid antigen tests, or maybe in some places, some of the rapid molecular tests. But these things have to be used, and it would be really good to have these near patient solutions influencing care and impacting the lives of the patients. So I think what I talked about kind of throughout this is engendering this confidence to not initiate inappropriate antibiotic use or hedge your use. So for example, imagine you had somebody that came in with a pneumonia that you diagnosed on a chest x-ray. You could do viral testing coupled to bacterial testing. So you might test that person for flu, COVID, RSV, and that helps you understand what's going on. And this can be done in an outpatient setting. It actually guides people on the right pathway, even if it's not in some sophisticated hospital setting or an emergency department setting, that it's in an urgent care setting. You can guide people to the right clinical pathway by using this testing use, even for something like pneumonia, where you might traditionally just reflexively prescribe antibiotics without even doing any diagnostic testing. You might do a chest x-ray, you see an infiltrate, you put that patient on Augmentin or Azithromycin or whatever it might be. But take a step back and think, could I use tests to actually narrow this down a little bit to say, this is not influenza pneumonia, this is not RSV pneumonia, this is not COVID pneumonia. That, I think, is how I would incorporate it in an urgent care setting, because, I recognize in an urgent care setting, you don't have the whole day to do this. You've got to move people very quickly. You don't have everything at your hands the way you do in an emergency department in terms of being able to use a hospital lab. So I think that you can use the rapid point of care antigen tests in urgent care settings very effectively. So let's think about the upcoming respiratory season. So right now, we're at low activities of both influenza A, influenza B. COVID is kind of at a lower level now after coming off of its summer peak. And RSV is starting to pick up. The RSV usually comes first, and it is starting to increase. So what you could start doing today, right after you're done with this webinar, is start thinking about using point of care tests as a critical component of triaging persons to the correct treatment pathway. Do they have RSV? Do they need influenza antivirals? Do they need COVID antivirals? Do they have group A strep and they need antibiotics? Do you need to give antibiotics to these patients? And then I think, as I said earlier, patients are increasingly interested in what's causing them to be sick. And that changes their behavior. When they think they have some virus, so they just have a cold, they may not really think much of it, but that cold could be caused by COVID. That cold could be caused by influenza. It could be caused by RSV, and that might cause them to maybe wear a mask, or maybe not go around an immunocompromised individual, or maybe tell their friends that they're sick and they're not going to go to the party tonight. That it changes behavior when people have a specific diagnosis, that they have influenza, not some virus where they don't know if that's to be blown off or not to be blown off. When they have a specific virus, they can look that up. They all look up what they have, And then there'll be specific guidance from the CDC. You should stay home until you don't have a fever or whatever it might be. And that changes their behavior. And even if you get a small, you don't get 100% of people doing that, you get some percentage of people doing that, that's going to have an impact in onward transmission and protecting vulnerable populations that might be in contact with those individuals. So I think that there's a lot of benefits to knowing why people are sick. And I think that urgent care is a nexus where point of care tests can have a major impact with diagnosis, triage, treatment, stewardship. This is something where you're the frontline provider that people see. You may be the only provider that people see. So you can really set the stage for them getting the right treatment, knowing what's making them sick, so that will kind of dictate what they do after that and what kind of follow-up they may or may not need. It helps the next doctor or provider down the line that you've made a diagnosis and so they have some idea of what the prognosis might be or how long they've been sick. And then there's an epidemiology role because in your community, then they'll know what's going around. And as I said before, if things are going around and everybody's testing negative, that's a signal to public health that something odd is going. And I'll give you a couple anecdotes in a second. I just want to see where I'm on my slide. So one of the anecdotes that I think of to really illustrate what happens when you actually diagnose things has to do with the 2009 H1N1 pandemic. And that might have faded from a lot of your memories. I don't know what the average age is of people listening. Some people might not even have been practicing at that time. I was in infectious disease fellowship when it happened. And just to remind you, so this was April of 2009. And what we started to hear were there were cases, or there was some illness going on in Mexico. We didn't really know what was going on, some respiratory illness in certain parts of Mexico. And pretty rapidly, around the same time, we hear about 2 kids in California that have been diagnosed with a untypable or a new type, initially untypable influenza virus. So these 2 children went to clinics, urgent care type clinics with mild influenza-like symptoms that were part of a research program that was testing and typing every type of influenza virus that came along. And what happened was they did their little test and it came out as an untypable, the influenza A positive, untypable. And those got sent to a reference laboratory. And that reference laboratory discovered that this is a novel H1N1 virus, which then happened to turn out to be the same virus that was spreading in Mexico. And that led people, so then you actually knew that this virus had already, by April of 2009, had already spread from its origin source in Mexico to the United States. So that changed all of the thinking, because again, flu, if you go back to what I said earlier about viruses that are contagious during their incubation period, influenza is one of those. Influenza is also contagious when people have mild symptoms, as you all know. So that set the stage for not doing kind of unnecessary things. We already knew that it was out of Mexico, so that any kind of wasted efforts on travel screening or travel restrictions was not going to work, because it was already in 2 little children in California. And as we tested more, we realized it was all over the country. But the initial impetus to understand this virus, to know that it was here and that it was spreading, was urgent care setting testing for influenza. And that was the signal of a new influenza pandemic, the first pandemic that we'd had of influenza since 1968. And it was discovered in an urgent care center. So I think that I can't overstate enough the role of urgent care centers when it comes to thinking about infectious disease and being part of the system of care for infectious disease and our early warning system, because all these individuals are going to show up in urgent care settings or emergency department settings, and which have some overlap. So I think it's really important that you really advocate and think about testing and getting those tools there. So, a couple of things that I want to really emphasize is that these are major developments, that we didn't have the ability to diagnose things that easily for a long, long time. And we've come to the point now where we can diagnose ourselves in our house, in our home, for COVID, for influenza, for syphilis, for HIV. These can all be done at home. and I have this vision, we're here talking about antigen tests that could be used in urgent care settings, but just to kind of for me to be aspirational, I have this idea of, and do people remember the Jetsons, that TV show set in the future, where it was a cartoon when I was a kid that was pretty popular, and they had all these awesome devices. I always think that it would be great if we could have devices like that, kind of that test us for lots of things, that you just do a nasal swab of yourself or a throat swab of yourself, and you stick it in some kind of toaster oven type device, and it spits out what you have. And at the same time, it links you to telemedicine to get a prescription for something, or links you to your doctor. And it also transmits that to the local public health department so that they know what's making people sick. That's kind of my vision of success in the future. It doesn't have to be in people's homes. That's one place. It can be in urgent care centers where people can check in and know what they have, and be able to then go on with their lives and give us lots of situational awareness of what's spreading. But there's no technological barrier to that anymore. All that exists. And I have a picture there of the three of the people from the Star Trek, including Bones there, and Spock is holding something called a tricorder. And I don't know if any of you remember that tricorder, but it's basically a device like the size of a big phone, maybe like an iPhone Plus or something, one of those that people could, that Bones would take and scan up and down a person, and it would give him a diagnosis. We basically have a tricorder culture now. It's all of that technology exists. And the most frustrating part of it is that they're not being used. And the tricorder doesn't necessarily have to be one device. It's the whole panoply of tests that we have and the ability to get results rapidly. That's what was really great about the tricorder, not this fancy waving it up and down on their body, but they knew immediately. And that's what antigen tests can do when you employ them. And there are other tests as well that might need to be done second line or in addition to antigen tests. But remember, knowing the results fast is really powerful information. And that's why the tricorder was something that everybody really envied. Every doctor wishes they had something like that. But what's happened, as I said, is it's not a technological barrier. We can do like cell-free genome sequencing and know exactly what, it can test for like 100 different things in the person's blood. It's really this silo-based thinking and balkanization. What I mean here is, in many healthcare facilities, these people think of these types of expenditures on tests, whether it's a big fancy machine that you put in your lab or point of care tests, as a capital expenditure. They don't actually see the benefit of it. They think, oh, that's just a cost. Is it going to be reimbursed? How are we going to get insurance to pay for that? Not thinking long-term about, does this improve our ability to diagnose infectious disease? Does it reduce costs in the long run because we're not prescribing inappropriate antibiotics, or that these patients are now getting put on antiviral therapy, so they're not going to have an ER visit later. They're not going to have a hospitalization later because they're already on a drug that's going to prevent that from happening. People don't think that way. Normal people think that way, but oftentimes hospital administrators don't think that way. They're not thinking about it in the long run. They're thinking about the quarter or whatever it might be. And then they also kind of silo these budgets together. So like in a hospital, you have a great diagnostic test that reduce length of stay. The pathology department's going to complain if it costs a lot of money, if it comes out of their cost center or whatever, and it hurts their budget, even if the overall hospital budget is better, because now you've reduced length of stay by 1 day or something. So you can even save money, and they'll complain because it's not quote unquote saving money in one budget. So that's what I mean by this silo-based thinking. Lots of people are in their own silo and say, oh, we don't want to spend all that money on these diagnostic tests because it doesn't matter. We don't care about length of stay because we don't get judged on that. There's not this kind of holistic way of thinking about a healthcare facility or the whole ecosystem. And I think that's restrained a lot of people from using these tests or having them implemented. COVID-19 changed a lot of that because hospitals were in dire straits trying to be able to test, and they couldn't initially test for COVID, which is a whole other story you can ask me about, but they couldn't test for COVID initially. So they were testing for other respiratory viruses and then using that as a way to say, okay, this person tested negative for everything else, this is who we're going to test for COVID, when COVID testing was so restrained, even though there were co-infections. So that really wasn't a guarantee that someone didn't have COVID if they tested positive for metapneumovirus, for example. The other thing is that sometimes people don't, especially when it comes to rapid tests, point of care tests, CLIA wave tests, Sometimes you see pathology departments don't want to give up that control. They want to be the ones that are the arbitrator of all the tests. They don't want emergency departments, urgent care centers, or ambulatory centers to have all of those tests at their fingertips, because that decreases the lab's clout in the hospital or healthcare system. So that kind of like this fiefdom that they have that they want to control, that's also constrained the uptake of diagnostic testing for infectious disease, where they want it to go to the lab, and then it becomes cost prohibitive, especially if you're in an urgent care center that's off-site, of maybe you're affiliated with a university or affiliated with a hospital system, and you're off-site, so you don't have there's no instant courier to get that to a place to run. That can be a barrier, because the pathology department says, well, we don't want our urgent care centers to have these tests, because they don't want to give up that kind of power. And I've seen that happen and constrain the uptake of these tests. So that's another major issue. And I think that, the best way, as I kind of said, the best way to empower physicians, APPs, any provider, is to make the correct clinical decision. That's what we're trying to do. We're trying to get it right. Is to place these tools in their hands. So I don't think that these things should be locked away as if we shouldn't be using them, or be something that you have to go through hoops to use, or there's massive delays that are built into the system to discourage ordering. I think that's the wrong way to do it. If the goal is actually to make the correct clinical decision, this needs to be in people's hands. And I hope that those of you listening will kind of take that as kind of a clarion call to argue that if these CLIA wave tests and rapid antigen tests exist, we should be having them we should have access to them, that there's a need for them, and it will improve patient flow and improve outcomes, and not be in a situation where you're stuck with biological dark matter, where you don't necessarily know what's making people sick. And in my mind, I'd have all the urgent cares be just like the ones during 2009 H1N1 that were able to pick things up and really alert the world about a new virus because they were testing. So that's the kind of the message I want to give to you here, is that these tests are really important in terms of infectious disease control, in terms of having situational awareness of what's spreading in a given community and what actions need to be taken. But they're also really important for the patients in front of you, to make sure they're getting the right treatment, that you're preventing complications, that you're giving doctors that see this person down the line a clue to what's making them sick. But that's only if people use them. And I think that's what I've been frustrated with for a while, is that this is not a technological barrier problem. This is a culture problem, and no pun intended, as an infectious disease doctor, it's not a bacterial culture problem, but it is a culture problem that needs to be broken, so that we actually use these tests, and infectious disease comes into the 21st century. Again, just remember, think about with cancer or rheumatology, how specific the diagnosis gets. They sequence a person's tumor, they give them directed therapy. We don't do that in infectious disease. We've gotten spoiled with broad spectrum antibiotics, and throwing that at patients isn't the solution, and it obscures what's making people sick, and it leads to antibiotic resistance. So I think that's my last slide. So I've got about 15 minutes or so to take any questions on this topic or any other infectious disease topic that you might want to ask me about. I hope that was interesting to you. I hope that was valuable, and I hope you make some interesting and cool diagnoses this afternoon or the next time you're working in an urgent care center. So thank you again for listening. Thanks for the opportunity to present, and thanks for BD to BD for sponsoring this.
Thank you so much, Dr. Adalja, for sharing such a valuable insights. Your expertise and your perspective has really given us a lot to think about as we plan for the future. So now, as you mentioned, we'd really like to open up the floor for questions. Feel free to drop any of the questions that you may have in the chat box, and we'll get to as many as possible in the time that we have. This is a great opportunity to dive deeper into some of those topics that we covered during the webinar, or even address any specific thoughts or concerns that you may have. I'm going to go ahead and keep an eye. Again, feel free to drop any of the questions, comments, or concerns that you may have within the Q&A box at the bottom center of the screen. Alrighty, so we've got one question coming from Stefan. Many of us are business owners, so I was hoping for some insight into tests that have a great reimbursement and low costs.
So some of that is a little bit outside of my realm of expertise on the reimbursement and costs for them. But in my understanding, most of the rapid antigen tests are reimbursed fairly easily. Where there have been problems have been multi-analyte tests where maybe it's testing for 5 different things, and some insurance companies might say we're only going to pay for something that tests for 4 or less, or it's something, there's some cutoff that they have for where that price point is, or where an insurance company will not reimburse for. So that is an issue that happens when, for example, you send a 20 analyte test from an urgent care center. It may not be reimbursed and you might have to fight with them. But I would defer to a billing expert on that rather than myself, because I don't actually know it in more detail than that. But it is an issue, and it is something that we've been trying to advocate for, at least from the IDSA perspective, for laboratory testing to be something that is easily obtained, because it has multiple benefits outside of just the individual patient. Because if people are disincentivized to test because it costs too much, they won't test, and then we won't know.
Great points on that one. So building on that question, again, feel free to drop any more questions or comments that you have in the Q&A chat. Let's see here. So we've got some more comments coming in. Is a 4-plex PCR panel for respiratory better than individual antigen tests?
So it depends on your situation. So they're both going to give you different. So there's a general question of what's better, what's a better test, PCR and antigen tests, and then there's a question of should you do the individuals versus the PCR test. So just one step back. So PCR PCR is definitely a very sensitive way to diagnose things, and it may be the appropriate test. But what I would say is kind of my practice in general is, if there are antigen tests available, you can have the nurse kind of do the swabs at the same time and do an influenza COVID test on rapid antigen test. And then if that's negative, move to a PCR if you're trying to figure out what's making someone sick. But it all depends on your turnaround time and what you have available. So because when the rapid antigen tests are still going to give you a faster result than the influenza, than a PCR test. So if you can get that answer, you can stop. You don't have to keep them around. In most places, the turnaround time, I think, will probably be at least an hour to get that. So I often will do the antigen test in my emergency medicine setting. I'll do the antigen test first. If those are negative, then I send the 4-plex PCR for flu A, flu B, RSV, and COVID. And if they're really sick or they're getting admitted, I may send a whole respiratory pathogen panel if the antigen tests are negative. So I still use those first, but I think a lot of that's going to depend upon the situation, how well you can get the nurses to swab, because sometimes they do complain if they go back and swab again. But antigen tests have the advantage of giving you the answer very quickly when they're positive. So an antigen test is not going to give you a false positive. If it's positive, it's very unlikely that it's a false positive. It's going to be very specific to the diagnosis, so you can stop there. But if it's negative, you have to think, do I need to do more testing? Should I do a PCR for the same pathogen, or should I do a wider PCR test in order to find out what's making this person sick? So that's the kind of way that I kind of tier them, is I use antigen tests first if the logistics are in play at a given facility.
Great. We've got another question coming in here. It says, what do you think about possible overuse of a rapid group A strep POC testing in UC?
Well, I think that there can be overuse if you clearly know that it's not going to be group A strep. But I think, so we have things, and people know about these things called the Centaur criteria that kind of differentiate viral pharyngitis from group A streptococcal pharyngitis. So if this person has a sore throat and they're coughing and sneezing and that they've got this whole respiratory syndrome, you probably know right off the bat that this isn't group A strep. So I probably wouldn't test someone like that doesn't meet any of that's clearly getting ruled out by Centaur criteria. I probably wouldn't test them at all for group A strep. I'd probably test them for flu and COVID before I would test them for strep. And as I said, I probably wouldn't even test them for strep. However, if you're getting pushed in a corner where you have to give them antibiotics, I definitely would use the test in order to not give them antibiotics, to prove that you don't have to give them antibiotics. So I think there can be overuse if you're doing it on every person that clearly doesn't meet criteria for group A strep because they've got other upper respiratory symptoms. And most group A strep cases are going to be like isolated fever, lymphadenopathy, exudative pharyngitis, and absence of cough. Those are the Centaur criteria. They usually fall into that, or they have some of them. They don't usually have, the cough, runny nose type of thing. So I wouldn't be testing those people for group A strep. At least I wouldn't personally.
Great response. We've got another one coming in that says, what is the time to result requirement for the POC test in an urgent care setting?
I think if something comes back within 15 to 20 minutes, I think that's a reasonable time frame, and most of the rapid antigen tests do result within that time period. I mean, it may take longer in terms of triage and getting the specimen, but the turnaround time is pretty short. And there are some urgent cares that are probably using molecular tests with longer. So I think it all depends on the workflow at your place, what your waiting times are, and what you're trying to do. But I think most antigen tests are going to give you a result within 15 to 20 minutes, which I think is acceptable to most patients.
Awesome. And a bit forward thinking, how do you see POC testing evolving over the next decade, and what kind of impact do you think that might have on urgent care?
I think that POC testing is going to become more widespread in terms of more things you can test for. So right now we talk about the big three viruses: COVID, flu, and RSV. I suspect that will expand to maybe things like metapneumovirus, maybe adenovirus, maybe some bacterial pathogens like mycoplasma and pertussis. And there will be more molecular point of care testing that becomes more easier to access. It won't all just be antigen. There'll be molecular versions too that are more widespread. There will also be a lot more home tests available, I think. Right now, flu is the newest home test that we have for respiratory viruses. There probably will be others like RSV and maybe even group A strep that are devolved to home testing. So I think urgent care centers will likely have a bigger menu to choose from, and patients themselves will have a bigger menu to choose from with point of care tests. So I think it's only going to increase. I think that COVID got people interested in what they're sick with. And people have seen, companies have seen fit to make flu tests now. So I think that people will still continue to want to know what's making them sick, and that's going to, and they're going to hopefully have more antiviral options as well. So likely you're going to see, I would think, an increase in point of care testing in urgent care settings, as well as in home settings.
Great, thank you so much. And just thinking about regulatory considerations, given the rapid development and deployment of POC tests, can you speak to any, current regulatory hurdles that these tools face and how those might evolve?
I mean, the biggest regulatory hurdle is that these have to be CLIA waived. So the FDA has to be in a position to think that the FDA and CMS have to be in a position to think that these are things that can be done in low complexity settings by almost lay people or not skilled laboratorians. So that's one of the biggest regulatory barriers, is doing those studies to show that it's safe. That's been the biggest regulatory barrier for home tests as well. There was a lot of reticence. It took about a decade to get a home HIV test through the FDA, although they've now been much better than they were in the past. But it's really just doing the studies to demonstrate that these things can be used in that setting. That's the hurdle, and that it's worthwhile from a company's perspective to invest in these things as point of care tests rather than have them kind of sequestered in the lab.
Great, thank you. And another question coming into the Q&A chat. Do you foresee testing for AMI in an urgent care setting? For example, would urgent cares want to test for troponin 1?
I think it would be useful for that kind of testing. I was talking here about infectious disease, but yes, I do think knowing that this patient has a high troponin may help with onward triage to make sure they're going to the hospital that has cardiac capabilities. You're not going to send someone home with a negative rapid troponin. If they're coming in with chest pain and you're thinking, I'm going to be testing a troponin on this patient, they probably need to be formally evaluated in an emergency department setting, because that's only one moment in time. However, it's the positive troponin that could lead to quicker treatment, triage to a cath capable center or a cardiac center. That I think would be useful, and it would be useful to the receiving facility to know this person that's coming in with chest pain it's not musculoskeletal because their troponin is XYZ. So yes, I think there would be use for it, but it would be not in ruling anything out, but it would be to guide prognosis and guide transfer decisions, and to give information to the next provider.
Great, thank you. And I think we've got about time for just about one more question. I see another one coming in through the chat, and it reads, should urgent care centers adopt rapid, less than 20-minute CLIA wave PCR tests and ditch antigen tests as the reimbursement is higher and the profit margin is better for PCR tests?
I don't know the financial part of it, but I think that you kind of have to look and see what's available on the menu. And I'm, even though I'm talking on BD and they make antigen tests, I'm also a big fan of rapid molecular tests. I would look at the panels available to make sure that you're covering all the pathogens you need to test for, and then kind of make a business decision. I don't think you can go wrong either way. So I think it's going to be based on your reimbursement. As long as you're covering the same pathogens with the same turnaround time, I think that I would look at it as a business decision, rather than anything else. As long as you're getting as long as you're being able to test for everything you need to test for, and some things it might make more sense to test with antigen, versus depending upon what's on what panel. So just keep that in mind as well.
Amazing, and thank you so much. If there are no further questions, we'll go ahead and wrap up. And as we wrap up, I'd like to remind all of you of our next webinar that will be hosted tomorrow, December 5th at noon Eastern Time. The title of that webinar is Surprising Insights from Your Urgent Care Payer Data, presented by Aptitude Medical Systems. But again, thank you so much, Doctor, for coming here and for sharing those remarkable insights. And thank you so much to the audience for your engagement with those questions. We really appreciate you taking your time and attention during today's webinar. We hope that you found this session valuable, and we really look forward to connecting with you in the future. Of course, if you have any more questions, if something comes to mind later, feel free to reach out to us directly at admin@neruca.org. We're always happy to continue the conversation. Again, we really appreciate your time and participation today. So with that, I'll leave you. Have a wonderful day, and we look forward to seeing you at our next session.